you may ask me, how is it that I, a gastroenterologist, am involved in this? The reason I'm involved is that I happen to chair a hospital which has got a group of very highly qualified internal medicine people, pulmonologists, interventionists, infectious disease specialists, and of course, cardiologists, and all together. When COVID first struck us, this group of people, about 56 of them, got together and decided to make so-called COVID protocols and guidelines. Every week, they would look at the literature that's coming in, critically study it in a graded form, see what information is right or wrong, look at grade based on RCTs, meta-analysis, and so on, and come to certain conclusions. And just about a few weeks back, we finished a series of COVID protocol guidelines, which is available in YouTube and is now being published as a book, which is also will be available in our website. So this was my attachment with this, and having attended all this and been there and been involved with this group who've been treating these patients, about 20,000 patients have been treated in our hospital, and I think with the mortality rates which are slightly lower than the national average. So we decided to bring all this wisdom together to have these guidelines and come out with this. There are many guidelines available in the literature. There are guidelines which are usually Indian, like the ICMR guidelines, the Ministry of Health guidelines, the AIMS guidelines. There are also guidelines which have come from different national agencies, the Mayo Clinic guidelines. The most respected or the most followed one is the NIH guidelines, the National Institute of Health guidelines. The NIH guidelines are one which is some basis in which I'm going to. The reason why it's important to follow only one guideline or one protocol is there's a lot of confusion among the literature. And I think Raman has given a brilliant lecture on how so many ifs and buts and so many contradictory statements are there. So if you start following all this, you'll start getting confused. So for a practicing physician, what does he want? He wants to have a clear-cut idea of what to do in his patient. And what I'm going to do over the next few minutes is try and give a clear-cut idea, avoiding many of the controversies. And I'm going to show you what is the AIG COVID management algorithms that we developed and how we've been very successful in treating these patients. I'm going to first start with two slides, which are the most important ones. I'll come to those two slides. You listen to these two slides, they're enough. You don't have to go through others. We're going to start about the initial management strategy, briefly about many of the pharmacotherapies which Raman has dealt with, how to prevent complications, and to summarize briefly. But first, before, you have to understand that there are various diagnostic components of how we're testing. Suddenly, into our diagnostic armamentarium has come IL6, D-dimers, ferritin, and so on. We're not doing this earlier. But now when you start doing this, that even in viral fevers, very often we find an IL6 elevated. So my colleagues sometimes come up with reports somewhere else done saying he has COVID because IL6 is elevated. This is wrong. These are non-specific. They don't have anything to do with COVID. We just got awareness of this because we're doing it more. Now, the most important, of course, is RT-PCR, and it's important to be aware there are several fallacies in this test. 70% positivity, even the standard RT-PCR, 50% is rapid test. But one important thing is that this variation occurs not only because of labs, but because of how the swab is taken. And we have recently published a large study to show that in those who are RT-PCR negative, if you add sputum, your chance of positivity increases to 90%. So my suggestion to the practitioners is, if you are repeatedly getting RT-PCR negative 1, 2, 3 times, the third time kindly don't do only RT-PCR in a suspected case, but add sputum in the same sample of the patient, and you'll find that your positivity goes up to more than 90%. This is just a practical point I want to tell you about. Now, understanding the components of treatment, we have gone through all of this, and I think a lot of literature is against so many medications. So let's briefly look at, as I said, these are the two important, next two slides are the two important ones, very simple ones, which will, I think for the practitioners, very important because you'll really understand how these patients should be treated and what is the mistake we're making in treating these patients. The important thing to understand is that this COVID disease has a biphasic phenomena. The first week or 10 days is a viremic phase. The second, from 10 days onwards, it's a cytokine phase. So whatever treatments we give in the first 1 week or 10 days should be against the virus. So if you're giving Remdesivir or any antiviral drug, it should be against the virus. You should not use corticosteroids in this phase because you'll increase the viremia. The second phase is cytokine phase, where the most of the damage is because of increased cytokine. It's an immunological phenomena. So in this case, antivirals like Remdesivir will not work. At this stage, only steroids are going to work, and that's a famous recovery study we'll come to a little later. So in this phase, we should not give mostly not depend on antivirals, but depend on immunosuppressants like steroids. So this is very important. And basically, we have only two drugs, antiviral and immunosuppressants. Only 2 weeks. One should be used in the first week, one should be used. Very simple. Now, in fact, we have again published this very important study in MetaGene, where we've shown that in Indian patients, why the severity is not so much. The incidence is high, but severity, mortality rates are much less than Brazil, America, and so on, is because the virus enters into the body using an enzyme called TMP-RSS2. We have shown that in Indian subjects, the TMP-RSS2 is actually mutated, so it doesn't help the virus so much. And there's some very interesting discussion coming on that. We'll come later to that. But the second important slide I wanted to show you, this is a slide that all practitioners should sort of mug it up, because it's very important. Now, the COVID stages, because the whole treatment depends on that, mild, moderate, severe. There are various ways of defining it. The ICMR is given different definitions. Ministry of Health is given different definitions. The AIMS is given different definitions. And for our purpose and what we follow in our institute, and to make it very simplified, I'm going to discuss this NIH guidelines that have come. NIH guidelines basically divide COVID clinical features into 3 stages: mild, moderate, severe, right? Mild is fever, uncomplicated. These patients have mild cough, upper respiratory tract infection without dyspnea or hypoxemia. Very simple. Majority of patients fall into this. Moderate are those who have lower respiratory tract infection, usually lung infiltration with pneumonias and so on. The respiratory rate increases and oxygen saturation is still maintained. Here the confusion comes because in some of the local guidelines, they give oxygen saturation less than 94, but this NIH very clearly saying that oxygen saturation is still maintained. So moderate cases are those who have a lower respiratory tract infection. Usually they'll have more cough, deep cough, and they'll have, if you take an X-ray chest, you can see a pneumonic patch. Severe infections are the last category, who have a lung infection which is more than 50%, their respiratory rate is more than 30%, and their oxygen level starts to fall, less than 94. So this is the classic NIH guidelines, and kindly remember this because all your treatment depends on this. Now to this, we have added 2 other categories. The critical ones. The critical stage is when these patients develop ARDS, septic shock, multi-organ dysfunction, and oxygen saturation is below 90. Most of them come to us below 70 and so on. These are the critical patients. These patients, I'm not going to discuss in detail because they're going into ICU for ventilation. They require a variety of different types of intensive care treatment. But other spectrum is asymptomatic individuals who are becoming very important now because these are the ones who are transmitting the infections to us. They don't have any symptoms. And we're seeing more and more of these cases, especially those who are getting partially treated. So asymptomatic and, of course, before the infection, pre-symptomatic. So these are the categories. But remember, for a practicing clinician anywhere in the periphery, these 3 mild, moderate, severe category, keep this in your mind because this is going to tell us how we're going to treat. And if you look at how in clinical practice, more than 90% of the patients fall in this category, below this category, 90%. So you don't have to do anything for them. You don't have to do. That's why many so-called RMP doctors or Ayurvedic doctors are successful because you don't have to do anything. Patients are getting better. They get credit for this. It's only the 8% of the patients who actually develop this more moderate severe case, and 2% go into critical stage. And the average mortality is 1 to 1.1% in our country, maybe around less than that in our institute. So this slide I hope is clear to everybody. So these 2 slides which I showed you will set the stage for how we treat the patient, and we'll understand very clearly what we should do in clinical practice. So let me concentrate a little on mild cases because 90% are mild cases. And you don't do anything for this patient. It's very difficult not to do anything for the patient because they call, ring up, they'll come and say, I have this. They've got a lot of anxiety, phobia. So we have a grading system also. The clinical score should not exceed 8 in these patients when you call them mild. They have fever which is mild, not exceeding 100, occasional cough, no breathing trouble, no major fatigue, no diarrhea, and oxygen saturation is always above 95. So I sometimes ask our patients to keep a diary or a chart with them and just note down this and tell next 3 days you tell me what is the temperature, what is the cough pattern, is there any breathing trouble, is there any major fatigue, and so on. So they'll tell us and you can actually do a mental scoring or say that. So then you know it's a mild case. So what do you do in a mild case? 90% are mild case, right? So in a mild case, we'll ask the patient to take paracetamol every 8 hours for the fever so that he feels better. Even this is not necessary, but they feel better, body pains come down. So regarding vitamin C and vitamin D, somebody is interested. Or somebody is, I think I have to switch off their mic because I'm able to hear their mic. Can I go ahead? Okay, yeah.
Yes, sir. Good, please go.
So, vitamin C and vitamin D, of course, there's no evidence suggests it's useful. But as a practical physician, I can tell you what, patient requires something. Say nothing to be done, just take paracetamol, be in your house, they're not very happy. So something has to be given. There's no harm in giving C and D. There is some weak evidence against D that if you have a vitamin D deficiency, disease seems to be more. So, okay, give it once in a week for 2 or 3 weeks and you can stop it. So, this is general symptomatic treatment. As I said, as a practicing physician, this is very practical. Patients feel happy. And now that there is something against the zinc, maybe you can avoid that. But at least vitamin C, vitamin D, there should not be any problem. So you give this. And then you follow up the patient for 3 days. So 3 days critical. Mild case, only paracetamol, follow for 3 days. If in 3 days the symptoms are improving, then nothing to be done. Just leave the patient alone. Maybe he may require paracetamol for another few days just for this body pains and fever, right? So we continue monitoring the patient for 10 days. Earlier it was 15 days and now it's 10 days. 10 days time, you say that he's all right. He can now go back to his work and so on. We need not repeat the RT-PCR after 10 days because there is no evidence that doing RT-PCR after 10 days will help us in other ways. So now the recommendation is not to repeat it. But look at the other patient. Symptoms are not improving. His CRP is going up and the CBC also showing a neutrophil lymphocyte ratio. So if lymphocytes are going below 20%, certainly below 15%, you have to be very careful. Because these patients are going to develop into problems. So if you have a CBP, a lymphocyte neutrophil ratio or a CBP between 5 to 15, patient is continuing to have cough. The only evidence we have in literature which is accumulating is to give inhaled budesonide, 400 to 800 micrograms twice a day. So this is the only thing we give. And if they're improving, then of course we continue monitoring these patients. We monitor for budesonide on 3 days and slowly taper it off. So for mild cases, this is the only evidence-based treatment. There is no evidence that other drugs are going to be useful. Just remember this, very simple. No treatment, maximum they have cough with increasing CRP, give budesonide as an inhaler. But if during this monitoring of these 5 days, if the patient's saturation drops to below 94, this is a red flag. So ask the patient to keep a pulse oximeter, and pulse oximeter, there are variety available in the market. Be careful. Select a one. Some of these cheaper ones are not very good. So select one which you are confident and use this. So just to summarize, no investigation, symptomatic treatment, and there may be a role of inhaled budesonide. So again, now what about monoclonal antibodies? I just wanted to get this to you. Monoclonal antibodies. You can see here I put as query monoclonal antibodies here because there is some evidence that certain category of patients who can go from mild to moderate to severe, we can prevent monoclonal antibodies. How effective this is, we are still studying now. But I think this is very important information. Again, physicians should know because monoclonal antibodies are now available. Cost is not a factor because people going to severe disease, they're spending 60,000 to 1 lakh rupees per day. If you can prevent that and give one shot of monoclonal antibodies, why not if it's properly indicated? So there's a lot of interest from a lot of people. So monoclonal antibodies now currently These ones are available for last about 10 days in our country. We've been using this. This is from Roche company, marketed by Cipla. The indications are more than 65 years, BMI more than 35, uncontrolled type 2 diabetes, chronic kidney disease, immunosuppression, or even those above 55 years if they have CAD, hypertension, or COPD. And even younger patients, BMI. So obesity is a major indication. So if you have an elderly patient, obese, uncontrolled diabetes, there's a strong indication for using monoclonal antibodies. You have to use half the vial. So for 2 patients, you can use 1 vial, half the vial. And very easy to give, half an hour, you give it and the patient, given as an outpatient. The question here is, it's so dramatic, you can predict which patients are going to severe disease. Now we have a list of all these conditions. So why not give it all the cases? The only problem is regarding how effective this is against our mutant strain. We now know the mutant strain that we have, the B1617, 1 or 2, how effective, we still don't know. We are studying it. In fact, we have now launched a major study in our institute where we're studying the efficacy of monoclonal antibodies, both in clinical situation and in lab, to see how effective it is. We'll get an answer in 3 to 4 weeks. We'll let you know that at that time, then we can be more aggressive about using monoclonal antibodies. So this is the information, latest information about monoclonal antibodies. What about convalescent plasma? Again, I think that very well with Raman. We are starting to use it less. Lot of confusion because it's been used wrongly. If we use convalescent plasma, it should be used properly. High antibody levels have to be detected. It has to be used within 1 week, not later than that, and so many other situations. So tending to use it less. Although my own opinion is that there may be a small role, a small window period, especially if we don't have monoclonal antibodies available. Same indication as monoclonal antibodies for convalescent plasma, but collect it properly, check the antibody levels. They should be high level, because then you're giving a polyclonal antibody to this patient, may be useful. That's what been our impression before monoclonal came in. Okay, that is about convalescent plasma. So you see, management of mild disease, to summarize, no routine blood investigation, essentially symptomatic improvement. Kindly don't go for all this ivermectin, zinc, so many other antivirals have come, not proven. They're producing a lot of side effects. Only inhaled budesonide, very role, no role for antibiotics. Every patient, unfortunately, when we see them, they come to us, is put on doxycycline for some reason. It put on azithromycin for some reason. Absolutely no role. These should be used only when there's secondary infection. Most important, monitoring. Clinical monitoring, symptomatic monitoring, pulse oximeter monitoring. These 2 things which can be done in the patient's house. So I just put down a chart. You can later look at it. What are the must-dos in these patients? And of course, ivermectin, a lot of controversy. ICMR has advocated at one stage. I personally feel no role. Supplements also a lot of this thing. Vitamin C, vitamin D, maybe you can use because patients want it, but others don't. Okay. So now we shift from mild cases. We are very sure how to treat them. So we know how to define mild case. We know how to treat it. Now we go to the moderate cases. Moderate cases, you monitor mild for 2 to 3 days. They don't respond. Fever is persisting with other clinical symptoms. At this stage, based on the clinical symptoms, you know that patient has pneumonia, lower respiratory symptoms. You can advise HRCT or other D-dimer and so on. At this stage, if severity of CT is more than 10 score or D-dimer is more than 0.5 micrograms, you know you're dealing with a moderately severe illness. And these patients, you better advise for hospitalization. So mild, no hospitalization, moderate, get into hospitalization. Especially if a moderate symptom patient has comorbidities like diabetes, hypertension, obesity, you don't even have to look at the other lab parameters. Directly, they go for hospitalization. And these patients, we are starting on Remdesivir, 200 milligrams first day and 100 milligrams for next 4 days for 5 days. And enoxaparin in a row for about 40 milligrams, that is not the therapeutic doses. So here, again, I want to pause a little because I think Raman discussed about Remdesivir, what happened, all the clinical trials and all. A little controversial, but we are advocating in our institute, and based upon the small RCT that's available in New England Journal, there's nothing negative against it. The side effects are very less. And we feel, in fact, we're publishing a large series of over 10,000 patients. We feel that Remdesivir, at present, we cannot do a randomized control trial because the ethical committee is not giving it. Observational studies suggest that remdesivir may be useful in these patients, and therefore you can start. There's no harm in starting. But it's important to monitor these patients with routine and, of course, IL6, ferritin, LDH, and D-dimers, and CRP. So this should be monitored. And these patients, if CRP is more than 20, we have to consider a combination of remdesivir with baricitinib. This is based on a recent Act 2 study that came in the New England Journal, where they showed that combining remdesivir with baricitinib. Now, baricitinib, for those who are not aware, is a JAK1 and JAK2 inhibitor. It decreases inflammation without the side effects of steroids. Mild side effects, but less than steroids. So it can be used more progressively. And fortunately for us, baricitinib, which was very costly, now the cost has come down because it's being in India. 4 milligrams dose is costing very less, 100 times what it used to cost earlier. So it can be used more often. Now, if the severity score of CT is less than 10, D-dimers are less than 5, you can still continue to monitor this patient, but in the hospital for a few days. So moderate patients, most of them require treatment, maybe with remdesivir and anticoagulants, but some group who are very mildly symptomatic, who have a CT severity of only 10 can still be considered to be monitored like mild cases. So just again for practicing physicians. Now we come to the more severe cases. Now, if the fever is persisting with other clinical symptoms, comorbidities are there, and now the patients become hypoxic, less than 94, sometimes less than 90. In these cases, of course, you can advise the standard markers and CVT severity index is seen, but these are the severe illness patients. So moderate and severe, the difference is oxygen saturation according to the NIH classification. Now, these patients, we start remdesivir, enoxaparin, and dexamethasone. Now, this is based on the famous recovery trial. Again, kindly start dexamethasone only in the second week, not in the first week. The biggest mistake in clinical practice, the biggest harm to patients in our country now is the starting of steroids immediately at the time of illness, that is first week itself. It's causing a lot of side effects, viremia, side effects, drugs, and dexamethasone 6 milligrams, not large doses. If you don't have dexamethasone, of course you can give prednisolone or methylprednisolone, hydroxyprednisolone. That's a different issue we can discuss. But usually these patients require supplemental oxygen. So when you give dexamethasone, it means that these patients are in supplemental oxygen. Maybe just 2 to 10 liters, but some of them require larger dose of them. But supplemental oxygen and dexamethasone go together. Kindly don't give dexamethasone patients just like that without supplemental oxygen. Very, very wrong mistake in clinical practice. I want to re-emphasize that. All the senior physicians here, you kindly educate the GPs and other people treating out there. The dexamethasone should not be used in settings other than this. Only then we will benefit. Now, you do your repeatedly, every 48 hours, you're doing your parameters. If the CRP is going up in spite of this, then you can add a combination of baricitinib. So you can give remdesivir plus baricitinib in this situation. A combination can be given in these patients. Now, what about other drugs like tocilizumab? Again, very rarely used. We use the ROAD. So, in fact, in managing severe cases, we have so-called ROAD and TOAD. ROAD is remdesivir, main oxygen anticoagulants, DEXA, for severe cases. TOAD is when you have to have tocilizumab. I'll come to that indications according to what NIH has given. Before that, remdesivir, I know there's a little controversy, but I am for it, and we can give for all moderate severe cases, especially if they're hypoxic. It had to be given within 7 to 10 days. Kindly don't start it after 10 days, again, not useful. So patient on a ventilator on 20th day, no point in starting remdesivir. If a patient is asymptomatic and having very high inflammatory markers, if IL6 is 300 or something, I think there's a role for remdesivir. Unfortunately, it has not been studied in this context. And unfortunately, it's very difficult to do randomized control studies with remdesivir at this stage. So management of moderate severe cases, you can see, is very protocolized test, supportive, pharmacological therapy, and oxygen. So remember this when you're treating patients with moderate or severe cases. Now, for those who are having more than 60 years and those who are having all these comorbidities, you have to be much more careful because of observation. The poor prognostic markers are lymphopenia, which is very simple to do, which I found to be very elevated CRP. Just 2 tests in small clinical practice, lymphopenia, elevated CRP. If you have access to IL6, you can do that. Elevated D-dimer and anticoagulation will link together. Kindly remember, that may not be always true. Just because you have a high D-dimer doesn't mean you have to give anticoagulants. There's some dissociation. Again, I don't want to go into too much discussion on this. Ferritin is another marker. Some of these patients have cardiac toxicity, even young people. So sometimes if they complain of chest pain, kindly be very aggressive in getting troponin done. Again, I'm not going to discuss in details of systems what happens with cardiovascular or pulmonary or gastrointestinal, because I'm discussing in general. Chest X-ray at basal level when the patient is admitted, and CT scan, again, lot of controversy. Even in the recent press, there's been a lot of fight between certain section of radiologists and pulmonologists. Radiologists advocating this, pulmonologists saying no, you can develop problems like, for example, cancer and all. But I just want to put it in context here. CT scan is rarely needed unless pulmonary complications are needed. But in patients who have clinical suspicion, RT-PCR negative, sputum chance also negative, then you can get a CT scan or alternative diagnosis like tuberculosis. But when a complication like pulmonary embolism, so-called happy hypoxia, some of these patients, saturations are very low. They sometimes don't look like they're looking very hypoxic, but these are the cases who have a pulmonary microthromboembolism. CT scan is very important because that will change the management. And of course, in post-COVID fibrosis. In my opinion, again, those are hospitalized. There's no harm in doing a CT scan of the chest, mainly to identify the CT severity, because there's some indication that high CT severity of more than 15 may indicate that these patients have to be treated more vigorously. But anyway, controversy, but CT scan, most patients, maybe one time is enough, no need of constantly going on doing CT scans. But if there is a complication like suspected pulmonary microthromboembolism, kindly get a CT angio done. This is making a lot of difference, because then you have to step up and go to therapeutic anticoagulation in these patients. Now, corticosteroids, a lot of controversies. In our institutes, we use as less corticosteroids as possible. We are against corticosteroids because, unfortunately, the recovery study gave a wrong impression that corticosteroids are panacea for these patients. Everybody, first day corticosteroids. Don't do that. Corticosteroids only in the second week, and dexamethasone only 6 milligrams orally, not higher doses. And then there's no proven role in increasing steroids. Patient is not responding, increase dexa to 12 milligrams. No, don't do that. There's no proven role. You have to monitor the side effects carefully, and steroids stop after 10 days or at the time of discharge. Don't continue steroids for a long period of time. Most of the side effects are because of steroids. Now, there may be some discussion on this, but I want to be very, very clear. And about tocilizumab, I already discussed. Again, we are using it very less, but again, very clear indications given by NIH. Recently hospitalized patient whose need for oxygen is increasing, then tocilizumab is indicated as a single dose, mostly, sometimes 2 doses. Tocilizumab, most of these people can develop secondary infections, so be careful about that, but that can be used now. Anticoagulation, there's several meta-analysis to show that more than 14% have some sort of venous thromboembolism. So routinely moderate or severe cases are, of course, those in ICU anticoagulations. Again, very important that oral anticoagulants are not so good. Low molecular weight heparin is better for several reasons. Not only is a good anticoagulant, but also it has got an anti-inflammatory, anti-cytokine effect, so may be preferable. And of course, when you detect microthrombi, you give therapeutic doses. Normally, we use 40 milligrams enoxaparin, but you can double the dose as a therapeutic dose. And finally, this is something that the practitioner need not go into, but should know briefly what it is, because these are the terminologies that are used by intensivists. So when patient becomes critical definition I told you, usually oxygen saturation below 90, usually 70 like that, multi-organ failure, septic shock. In these patients require a full therapy with a variety of things. They start initially when they have oxygen need for more than 10 liters, they start with NIV, which is usually CPAP like this. Then they're increasingly using a high flow catheter or nasal catheter, which can give up to 40 to 60. In the first wave, we used a lot of this, and we found that oxygen need is more and more. And now we realize that when oxygen availability is less, you have to be careful about high flow nasal oxygen supplementation, although these machines cost only 3 lakhs, they're cheap. Beyond this, they go into ventilator, and ventilator, when they go into ventilator, only 50% of the patients come out of ventilator. But what we are now increasingly found is prone ventilation. So out of the 24 hours, if for 16 hours they're done prone ventilation, they seem to improve. Not very easy, but this is one. And of course, ultimately, extracorporeal membrane oxygenation in some patients. Again, I want to just introduce this terminology for people to know. Very few people, less than 10% who go into ECMO come out. It's more for those people who can go later on to lung transplant. But just to know this terminology for a practitioner, what all this means. So just to conclude, what there's disease severity, this is again for you just to recapitulate what I told you to remember in an algorithm form. Patient is non-hospitalized, mild to moderate, kindly don't do anything. Maybe the patient can afford monoclonal antibodies. We are studying the efficacy in our variants now. It costs about 60,000. So you can think of this in those patients who are indicated specifically older age group, above BMI, above certain age and all. For a hospitalized patient, those who do not require oxygen, you can still follow them. There may be remdesivir, in our opinion, may be useful. Again, controversy. But those who are hospitalized require oxygen. This is the group who require remdesivir, not responding, remdesivir, baricitinib, not responding, dexamethasone plus remdesivir, and ultimately the last drug is remdesivir. And those patients who are in ICU requiring ventilatory support, you have to use dexamethasone and maybe a small group dexamethasone. We require tolizumab. And of course, those who are going to ECMO, very few survive. So this is just for you to easy. You see so many drugs, and we ultimately come up with only one or two drugs in this patient. So for those like me who are not so sharp, it's very easy to remember this, to treat our patients. Now, just a short thing on this long COVID or post-COVID syndrome, it's coming up. My belief is that for all the general physicians, internal medicine physicians, your next year of practice is going to markedly increase. You're all going to do very well because of this post-COVID syndrome. It's going to come up. We thought that once patient recovers, he goes off, he's okay, but now we're discovering the so-called long COVID. Of course, we know that when they affect the lungs, you can get fibrosis, and some of these patients can develop long-term interstitial lung disease like syndromes. But not only this, they're developing a variety of other lung, in fact, even incidence of obstructive airway diseases, reversible obstructive airway disease is increasing. A Japanese scientist called Ishiwa actually, initially in the first wave itself, looked at autoimmune antibodies in these people and found that there were 84 types of autoimmune antibodies which were produced. At that time, we didn't know the significance, but now we know that many of these patients are coming out with like rheumatoid arthritis, like symptoms, thyroiditis, a variety of autoimmune diseases are coming out now. And even diabetes, autoimmune diabetes are coming out. Similarly, CVS, young myocarditis, young blocks, CNS young blocks are coming. And more important is these neuropsychiatric syndromes, depression, fatigue, 20 to 30% of patients are continuing to have long-term. And this continues up to now. We have follow-up for 1 year. Now, one of the things that's connecting all these people is the gut microbiome. For me, this is of interest. We're studying this. We found that those patients who have COVID, the gut microbiome changes. Bacterioid contents are increasing, some of the other microbiome. And this gut microbiome changes is affecting the gut metabolites and giving rise to a variety of long-term syndromes in these patients. And some of them is so-called long fatigue, dementias, and so on, may be related to change in gut microbiome. And this may be a very interesting future topic. And finally, vaccine, because I think, again, a lot has been spoken by Raman. I'm going to talk only about few important clinical aspects, what patients ask, frequently ask questions. They ask which vaccine. There are 3 vaccines currently available in our country, the Covaxin, Covishield, and Sputnik. I tell them whatever vaccine is available to you, take the vaccine. The only difference is if you take Covishield and Sputnik, your one dose may protect you for a long period of time. Covaxin, 1 dose doesn't protect you immediately, so take 2 doses quickly, don't wait. Whereas with the Covishield and with the thing, you can wait. Sputnik, you can wait for the second dose because, in fact, there's now tendency to think of them as single-dose vaccines. What interval? Now, with Covaxin, definitely 4 weeks. Don't delay. With Covishield, now the government has gone up to 16 weeks, indicating that may be taken as single-dose vaccine. Is Sputnik 21 days. Now, we have also published this very important study, and some question has come up in this, that this study was published from our institute shows that if you have COVID and after 4 weeks or 3 weeks, if you take a single dose of any of the vaccine, Covaxin or Covishield, you'll develop very high dose of antibiotics. Single dose is sufficient. Don't waste and take a second dose. So this is what we have found. So when after COVID, if you have an infection, minimum wait 4 weeks, but now the government recommendation is 3 months. There are no contraindications, essentially, as Raman has told you. The only contraindication is pregnancy is still not clarified. Severe allergies in these patients, but children were still not giving. Side effects are very, very minimal. To forget about it, I think this is a myth that has been propagated. And can we mix Covaxin and Covishield, mix and match? Right now, we're starting studies. Taken, and when they take it by mistake, we found that when you mix this, your vaccine levels increases, the antibody levels. So you can mix and match. But more important than all this, even if we take the vaccine for next 3 months, COVID appropriate behavior, masking, physical distance, and all is still important. Just to show some of our data, when the first wave occurred, we had about, in our hospital, 2,000 staff. You can see 400 and odd became positive, which is approximately 20%. In between the first and second wave, we were able to vaccinate all our staff. Everybody was vaccinated. And when the second wave occurred, we found that the second wave, only 75%, which is 3.7% got infected. Definitely showing protectivity of this vaccine, 7.8. And what we found in our data, as you can see, is that we also looked at the variants. In the first wave, all our patients had this standard wild type, Wuhan type. But the second wave, you see, most of them have this B16171 or 2, you can see. And when we looked at our vaccinated people who developed the infection, they all had this variant virus. So all the post-vaccinated infected people were with the variant virus and not with the Wuhan virus, indicating this vaccine protects partially, and this partial protection is because of the new variant. And Raman was also telling us this danger that can occur. But fortunately, it protects. None of the people none of our staff were 70. All of them had only mild disease or moderate. None of them went into severe disease or had any deaths. So this is an important practical information I wanted to give you. So finally, take-home messages are: kindly classify your patients. Remember this classification, very important. Lab parameters and imaging play an ancillary role. Remdesivir, I believe, should be used in moderate severe cases. Steroids and tocilizumab, very, very selected. Be very careful. Anticoagulants used for 15 days and stop moderate severe cases. There's no role for definitive. And oxygen is very important as a supplemental role, especially in severe cases. And finally, to end, I'd like to thank Misat and say that still, I think for us, it's mask and vaccine which is going to get out of this. And hopefully we can prevent a third wave if all of us as a society take this very seriously, mask ourselves, physically distance ourselves, and take the vaccine, and see in 3 months' time if we can vaccinate everybody. Thank you very much.